Hello, my name is Robert Crutchley, and I'm going to discuss the pharmacology and current evidence on Sugammadex administration. Here are my objectives for the presentation. You can read them on your own. First, I wanted to provide a brief review of neuromuscular physiology. Initially following the transmission of an action potential through a neuron to the presynaptic nerve terminal, the excitatory neurotransmitter acetylcholine is released into the neuromuscular junction, also referred to as the synaptic cleft. Acetylcholine then diffuses across the neuromuscular junction to reversibly bind to the nicotinic acetylcholine receptors of the motor end plate. This stimulates the postsynaptic membrane to depolarize and triggers an action potential. The end result is a muscle contraction. Acetylcholine is then eliminated from the neuromuscular junction by the enzyme acetylcholinesterase or by diffusion. There are currently three classes of neuromuscular blocking agents: depolarizing, such as succinylcholine; steroidal, like rocuronium, vecuronium, and pancuronium; and benzyl isoquinolines, such as atracurium, cisatracurium, and mivacurium. Sugammadex is unique to other reversal agents by its mechanism of action. After intravenous injection, Sugammadex distributes through the plasma and binds to the neuromuscular blocking agents rocuronium or vecuronium to form a complex. The reduction of free rocuronium available in the blood plasma creates a concentration gradient with the neuromuscular junction. As a result, there's a shift of rocuronium into the plasma, where it is encapsulated by Sugammadex and thus inactivated. This process reduces the amount of neuromuscular blocking agent available to bind to nicotinic cholinergic receptors in the neuromuscular junction, resulting in the reversal of neuromuscular blockade. This process is similar to vecuronium. Sugammadex has a volume of distribution of 11 to 14 liters and an elimination half-time of 2 hours. It is primarily excreted 100% unchanged in the urine within 24 hours. In this slide, we'll discuss the differences between neostigmine and Sugammadex. Neostigmine has an entirely different mechanism of action compared to Sugammadex. Neostigmine inhibits the breakdown of acetylcholinesterase. By doing this, it decreases the degradation of acetylcholine at the motor end plate. This allows acetylcholine concentration available to competitively increase neurotransmission over the non-depolarizing neuromuscular blocking agent. However, it has a ceiling effect, unlike Sugammadex, which can reverse any level of non-depolarizing neuromuscular blockade. On this slide, we'll discuss Sugammadex dosing, which is based off of train-of-4 monitoring. The manufacturer recommends reversing with 2 mg per kilogram if the patient has recovered at least 2 twitches via train-of-4. 4 mg per kilogram following recovery of at least 1 post-tetanic twitch via train-of-4, and 16 mg per kilogram to reverse profound neuromuscular blockade from induction dosages of rocuronium. The dosages are also based off of the patient's total body weight. The following slides will discuss current research on Sugammadex efficacy and implications for your practice. A 2017 study from Herring et al. Performed a pooled analysis of 26 studies. They studied 1,855 participants to determine Sugammadex's efficacy with reversal of rocuronium and vecuronium-induced neuromuscular blockade. The study compared Sugammadex to neostigmine and found recovery from Sugammadex was significantly shorter than neostigmine. On average, recovery from rocuronium took 1.9 minutes compared to neostigmine at 10.9 minutes, for a train-of-4 ratio greater than 0.9. Vecuronium recovery was also shorter in the Sugammadex group, taking only 2.9 minutes to reverse compared to neostigmine's average of 17.4 minutes. The same study from Herring et al. Examined recovery from deep neuromuscular blockade, which was defined as 1 to 2 twitches on post-tetanic count via train-of-4. When neuromuscular blockade was antagonized following rocuronium-induced deep neuromuscular blockade with Sugammadex at 4 mg per kilogram, they recovered in 2.2 minutes, and the neostigmine group recovered in 19 minutes. Patients with vecuronium-induced deep neuromuscular blockade recovered following Sugammadex administration at 4 mg per kilogram in 3.8 minutes, while the neostigmine group recovered in 67.6 minutes. These findings demonstrate Sugammadex provides faster recovery from moderate to deep neuromuscular blockade than neostigmine. However, it's important to note that neostigmine is not indicated for reversal of deep neuromuscular blockade, which can account for its significantly longer recovery times compared to Sugammadex. One of the benefits of Sugammadex is the ability to reverse any level of neuromuscular blockade. A study of 66 patients who received induction dosages of rocuronium and within 3 minutes administered Sugammadex reversal at 16 milligrams per kilogram. These patients recovered from neuromuscular blockade within 1.7 minutes for a train of 4 ratio greater than 0.9. It's important to note that the recovery time is the time from administration of Sugammadex to neuromuscular recovery, not from the time of neuromuscular blockade to recovery. Additionally, a large multi-center randomized control trial found that Sugammadex administration within 3 minutes had faster recovery from rocuronium-induced neuromuscular blockade than the succinylcholine group. However, practitioners should take into consideration that these studies were done under controlled conditions and the anesthesia providers had the full doses immediately available in their room to reverse these patients. Some hospitals may not carry such large doses in their operating rooms, but research suggests if performing rocuronium induction that this would be another safety measure to consider in your medication cart.
Current research suggests that Sugammadex increases operating room discharge to PACU. This can increase OR turnover and efficiency, but there has not been strong evidence to demonstrate overall increased hospital discharge with Sugammadex over neostigmine. It remains unclear whether Sugammadex can decrease discharge times from the PACU. Residual neuromuscular blockade is a major concern post-operatively due to the risk of respiratory depression in the PACU and can ultimately increase the length of anesthetic recovery. Current research suggests that Sugammadex decreases the incidence of residual neuromuscular blockade. A randomized control trial of 154 participants by Bruckman et al. Compared the prevalence of residual neuromuscular blockade following Sugammadex versus neostigmine. Participants received varying doses of rocuronium based on the clinical judgment of the anesthesia provider. The Sugammadex group received either 2 mg per kilogram for moderate neuromuscular blockade or 4 mg per kilogram for deep neuromuscular blockade. The neostigmine group was dosed between 17.1 to 84.8 micrograms per kilogram per provider judgment, with a max dose of 5 milligrams. Presence of residual neuromuscular blockade was measured within 5 minutes of arrival to PACU, with quantitative accelerophy defined as train of 4 less than 0.9. Also, signs of respiratory distress and vital signs were measured. There was no residual neuromuscular blockade in Sugammadex group, but up to 43% of the neostigmine group had train of 4 less than 0.9 upon arrival to the PACU. Of the 43% with train of 4 less than 0.9, only 2 patients had clinically significant neuromuscular weakness, which had resolved with an additional dose of neostigmine in the recovery room. Future studies examining a larger, more generalized surgical population can help determine whether Sugammadex is superior to neostigmine for preventing residual neuromuscular blockade, but current evidence suggests it has greater efficacy than neostigmine. The following slides will briefly look at the use of Sugammadex in special populations. Currently, Sugammadex is not FDA approved for the administration in patients under 18 years of age. There is not a large body of evidence to establish the safety. However, current literature does suggest it can be used safely in this population. In addition to having safe outcomes, it has also demonstrated faster recovery times from neuromuscular blockade than neostigmine. Sugammadex has demonstrated efficacy in morbidly obese patients. Specifically, it has shown a decreased incidence of residual neuromuscular blockade, which is important in this population, which is already prone to postoperative respiratory depression. Dosing guidelines by the manufacturer recommended it based off total body weight, but this can become a very large dose in the morbidly obese population. Currently, there is some evidence that utilizing an adjusted body weight as the basis for dosing can be effective in this population. However, there lacks a large body of evidence to support this claim, and until more definitive studies demonstrate this dosing, safest practice would be reversing patients based on total body weight. Another important population that is important to mention are patients with severe renal impairment. The manufacturer does not recommend administration in patients with a creatinine clearance less than 30 milliliters per minute. Due to the primary elimination of the Sugammadex neuromuscular blocker complex through the kidneys, It is important to note the theoretical risk of neuromuscular blockade recurrence. This can possibly occur from prolonged exposure to these complexes, and it is unknown whether they can disassociate at these prolonged periods. Current evidence does demonstrate rapid reversal from neuromuscular blockade, but complexes have been detected up to 7 days following administration in these patients. Due to these findings and the small body of evidence examining this population, there is insufficient data to conclude safety in severe renal impairment. However, a promising study of ICU patients examined the effects of high-flux dialysis, which is the most common form of dialysis, on Sugammadex, and found this form of dialysis was able to remove up to 75% of Sugammadex. Future research should determine whether dialysis is a safe option for patients with renal impairment who receive Sugammadex. Currently, there are no human studies on Sugammadex in pregnancy, which is why the safety in pregnancy is not yet established. There is also no research on whether it crosses the placenta, but due to the large molecular weight, hydrophilicity, and polarity of Sugammadex, we can predict little placental transfer occurs. Overall, use of Sugammadex in this population should be based on whether the benefit outweighs the risk to the fetus. The most commonly reported side effects of Sugammadex were nausea, vomiting, pain, and hypotension. These side effects had increased incidence when higher doses of Sugammadex were given. The manufacturer also reports a 0.3% incidence of anaphylaxis, which is important to monitor for. The most common presenting symptoms of anaphylaxis were urticaria followed by hypotension. Lastly, bradycardia has been reported in case studies and is a rare side effect to monitor for. The manufacturer recommends treating with an anticholinergic such as glycopyrrolate or atropine if this occurs. Sugammadex has demonstrated drug interactions with terimifene, an estrogen receptor modulator and hormonal contraceptive. Terimifene has a high binding affinity for Sugammadex, which can possibly delay recovery when Sugammadex is used. Neostigmine would be a safer option in this circumstance. Also, Sugammadex can interfere with all hormonal contraceptives for up to 7 days. It is very important to educate women of childbearing age about this, and it may be advisable to add this to your informed consent. Although there are several reports in the literature of other drug interactions, these are the only drugs that demonstrated interactions conclusively. Lastly, some early reports when Sugammadex was being approved reported corticosteroids may interact with Sugammadex. However, these original studies were in vitro and in vivo studies that failed to replicate these results. Lastly, we will discuss guidelines on how to reestablish neuromuscular blockade after Sugammadex administration. After administration of 2 to 4 mg per kilogram of Sugammadex, wait 5 minutes to administer 1.2 mg per kilogram of rocuronium, or 4 hours to administer 0.6 mg per kilogram of rocuronium, or 0.1 mg per kilogram of vecuronium. If the patient receives 16 mg per kilogram of Sugammadex, it is recommended to wait 24 hours before administering a steroidal neuromuscular blocking agent. These dosing guidelines are based on patients with normal renal function. If you need to establish neuromuscular blockade immediately following Sugammadex administration, then succinylcholine or benzoisoquinolines such as atracurium, cisatracurium, or mivacurium are advised.